So today we will see how can we approach to a patient of an MDS and from a pathologist perspective. So today we will be going about something about diagnostic approach, 2-3 slides about that, differential diagnosis, morphology, and some of the cases. So this slide I have explained in the previous session itself. So in an even case of MDS, when we are having a patient presenting with cytopenias or features of clinical features of MDS, first of all we should do the blood counts, and afterwards we should do a bone marrow to look for dysplastic changes, and do an iron stain to look for ring sideroblast and number of blasts, and also cytogenetics. So this is the first step we have to do, and second step is to make a diagnosis of MDS based on WHO criteria, and third step is to put those criteria into IPSS-R to find out the evolution of AML and expected survival. So this now fourth step is also been added, that is that molecular profiling, because in future it will be also added into the diagnostic approach. So this is the thing I have explained. So unexplained blood cytopenia, and look for morphological assessment of bone marrow and peripheral blood counts, and look for blast and cytogenetics, and based on that we will classify the MDS subtypes, and at the same time we look for that IPSS-R criteria that has 5 categories. So there are 5 categories: a very low risk, intermediate, high risk, and very high risk. And additionally, the fourth step to look for molecular panel. So in some cases, it might be very useful in prognostic as well as for even diagnosing the case. So cytogenetics we are having very good. In that very good group, we are having a deletion 11q minus y, and in good risk group we are having a normal karyotype, isolated deletion 5q, and isolated deletion 12p, and isolated deletion of 20q, and double abnormalities that include deletion 5 without any other TP53 or other high risk cytogenetics. So in very poor we can see they are having more than 3 abnormalities. So we can see that corresponding median survival decreases as the cytogenetic increase progresses towards the very poor category. So before going into the diagnosis of MDS, we should know what are the common mimickers of MDS clinically. So clinically also as well as pathologically, because it is very much important, because MDS is more of a pathological diagnosis. Morphology is very much important. So most important among the differential diagnosis is the nutritional deficiencies. So we know that vitamin B12 deficiency commonly causes cytopenias, and it's one of the in India it's very common because most of our patients are vegetarian by diet, and that can also predispose to cytopenias, and we should keep it in mind and when we are before diagnosing MDS. And other differential diagnosis includes heavy metal exposure and excessive alcohol intake, and any history of drugs, biological lesion we should ask, especially when the patient is on tacrolimus, MMF, or if any history of any GCSF. In that case we can get many myeloid cells abnormalities having toxic granules type picture, and history of infection, especially HIV infection, and parvovirus we know that it causes erythroblastopenia, and also it can also cause pancytopenia presenting aplastic crisis. And any congenital disorders like CDA and congenital neutropenia also be kept in mind in a younger patient. When a patient is presenting with an chronic microcytic anemia in a younger patient, or even some adult patients requiring transfusions, we should keep it in mind sideroblastic anemia. For that bone marrow might be essential, and where we can find sideroblast. Also we might need to do molecular typing based on the suspicion of our case. And aplastic anemia, of course, it can present with pancytopenia or bicytopenia, and PNH can also present with pancytopenia. Apart from these categories, we know that malignant syndromes like MDS, MPN syndromes, AML can also present with myelodysplastic changes. So coming to the morphology of MDS, morphology of MDS, before doing that, we should do minimum. We should do a 500 cell count in bone marrow and a 200 cell count in peripheral blood. And in peripheral sphere also we can look for dysplasia, especially in the areas where we can see some of the dysplastic changes. And in the bone marrow or in the imprint, we should look for dysplasia in at least 200 erythroid precursors and at least 200 neutrophil and its precursors, and at least 30 megakaryocytes should be there to assess for dysplasia. And by definition, WHO definition, to say dysplasia, it should be present in more than 10% of the visible sublineages. So this is the table showing this WHO MDS defining morphological features of this erythropoiesis, this granulopoiesis, and this megakaryopoiesis. This is a cartoon showing an overall picture of an MDS. Here we can see at center we are having so-called ellipse. Ellipse is nothing but abnormal localization of immature precursors, where we can see blast-like cells, blastoid cells present at the in between the intertrabecular area. And if we do a CD34 immunostain, we can categorize it, and we can see clearly they are also localized in between. So this is one of the features of an MDS that can be assessed in bone marrow biopsy. Apart from that, we can see some colonies of erythroid hyperplasia, which are showing megaloblastoid changes, and some cells are showing binucleated cells and trinucleated cells, and the morphological features of this erythropoiesis. And neutrophils can also show binucleated pseudo-Pelker anomaly, and also megakaryocytes can generally will present as hypolobated nuclei. So what are the features of dyserythropoiesis? So we can divide into two broad categories as nuclear and cytoplasmic. In the nuclear, we can have nuclear budding, we can have karyorrhexis, internuclear bridging, multinuclearity. Also we can see megaloblastoid changes. In cytoplasmic, we are having ring sideroblast vacuolization, and if you do a PAS, we can have PAS positivity in the cytoplasm. So this is the picture we can see. Whatever we have mentioned, we can see individually. The first picture is showing the nuclear lobulation, abnormal nuclear lobulation. In the second picture, we can see internuclear bridge. And the third picture, we can see cytoplasmic bridge attaching to erythroid cell lineages. The fourth picture, we can see karyorrhexis, and the fifth picture, we can see the binucleated erythrocytes. And the third picture, multinuclearity. Sixth and seventh picture, we can see the multinuclearity. And in the eighth picture, we can see some of the round vacuoles present in the cytoplasm. And abnormal hemoglobinization we have seen in the ninth picture. The 10th picture is a megaloblastoid appearance. You can see the abnormally large oblast with a very large nucleus, which is like immature looking. And in the 11th picture, we can see macronormoblast. And in the 12th picture, we can see a detached nuclear fragments. And in 13th picture, basophilic stippling. And 16th picture, we can see mitotic figure. And it is a giant erythroblast with nuclear lobulation. So any type of these type of things can be seen in this erythropoiesis, especially in cases of MDS. And we have to see at least as many number of cells, minimum of 200 cells, to assess dysplasia. And coming to dysgranulopoiesis, like we are having, this is what WHO mentioned criteria. So in generally we see a small size or unusually large size myeloid series cells which are having nuclear hyposegmentation, which is called pseudo-Pelker anomaly, and nuclear hypersegmentation, and decreased granules or any abnormally large granules like Dole bodies, or pseudo-Higashi granules, and any IRRs in the myeloblast. So this is the picture to show the same. In the first picture, we can see hypogranulation. In the second picture, we can see a ringed nucleus, and in the third picture, we can see hyperlobation and something called macropolycyte. And we can see here abnormal chromatin bridging, And in these three pictures, we can see the pseudo-Pelger-Huey anomaly. So dysmegakaryosis, WHO mentions three criteria for dysmegakaryosis. One of the main, among these, the most important is the micromegakaryocytes, which is abnormally very small, and they are mature appealing cytoplasm, and they will have an compared to the normal thing, it will be like around 10 to 15 times smaller than the normal megakaryocytes. And nuclear hypolobation is another important one morphological criteria. Apart from that, we are having multinucleation. So in normal megakaryocytes are uninuclear with the lobated nuclei. We can see here like this it will be present. And in this megakaryosis, we can see either multinuclearity, like individual nucleus will be present. So it's one of the patient like had this type of dysmegakaryosis in the peripheral blood. We can see some macro thrombocytes, large platelets with pseudonucleus type of morphology. In the bone marrow, we can see clustering of megakaryocytes, and many of which are showing eccentrically placed nuclei, and it is typical of an disease entity 5q deletion. So coming to the morphology of ring sideroblast, there are three types of ring sideroblast that have been described by the International Working Group. The type 1 has less than 5 siderotic granules in the cytoplasm. In the type 2 will have 5 or more, but not in the perinuclear location. The one which is having 5 or more siderotic granules in the perinuclear position, which is covering at least 1/3 of the nuclear circumference, is termed as a ring sideroblast or type 3 ring sideroblast. So this is our interest of choice in MDS. So either picture photo showing the different types of sideroblast. Here we can see this is a normoblast without any siderotic granule Napolitine. Here we can see in the second picture one siderotic granule, is a type 1 type of sideroblast, and in the third picture and in the last picture we can see there are multiple siderotic granules which are present in the perinuclear location. And in here also we can see which is covering at least 1/3 of the nuclear surface. So these are termed as an RSS, ring sideroblast. Right? If you see in this picture, we are having many siderotic granules, but they are not present particularly in the perinuclear area. They are present in the cytoplasm. So this will be like considered into the type 2 type of sideroblast. So these are the basics of morphology. So now we will go to the cases. There are 7 cases I am going to discuss. Some of which are very interesting, and all these cases are like I have seen when I am in my OPD, and I have followed up those patients, and these are real case scenarios of my own patients. So some are some interesting, and it's our many teaching point. Even I also learned many things from these patients. So first case patient is a 55-year-old post-menopausal female. She is a vegetarian by diet. She is symptomatic since 6 months with history of fatigue and weakness. She was relatively much active before 6 months. She has a past history of tuberculosis, which was diagnosed 1 year back. For that she underwent anti-tuberculosis treatment. She taken treatment properly, and recently only like before having these symptoms she stopped the AKT. So for these symptoms she went to a local physician 3 months back, who told her that she was having a severe anemia. So for that she received 1 blood transfusion. So after that she felt comfortable, but again started having similar complaints with a tingling sensation over the bilateral foot. So when she came to me, so she on examination she had a severe pallor, but she does not have any icterus, no organomegaly or no lymphadenopathy. So the basics CBC were 7.5 grams HB, WBC of around 3,300 at the normal differential count, and platelet 1.2 lakh, and MCV is 112, MCH 30 picogram, and MCHC 32, RAW 22, retic is 0.2%, and MDH is raised, which is 3,500. So what will you do next? So should I go for a bone marrow examination? Should I go for a vitamin B12 level, or I can just observe this patient, or should I think of PNH and go into analysis? So this is a classical history of, if you see in this investigation, a clinical history. So there are multiple clues are there. So the first clue is that he is a vegetarian. So in any elderly patient in a country like India, where many vegetarians are present, who are present with the anemic symptoms and a tingling sensation, and the third clue is being presenting with a pancytopenia, though not severe, but definitely it has features of pancytopenia. And there is a features of hypoproliferative anemia, which can be like seen with the retic count, where we can see retic is less than 1%. And in the picture we are having macrocytosis, which is more than 110 femtoliter. So to put into everything together, we can see that is a patient, is an elderly female vegetarian patient with pancytopenia, with macrocytosis, present with neurological symptoms, and which had a recent history of tuberculosis, also received ATT. So everything fits into the features of vitamin B12 deficiency. So vitamin B12 deficiency, what happens, like we know that vitamin B12 deficiency vitamin B12 is necessary for nuclear maturation, so DNA synthesis. So if it does not happen, then people can have macrocytic anemia. They can even, that vitamin B12 is also essential for other cell lines also, including your platelet production as well as your erythroid production as well as your myeloid series. So all the cell lines can be decreased, though not severe, but it can be decreased. So particularly if you go to the CBC of cells, so it is generally like well diagnosable. So we will have reduced RBC count, reduced HB levels, and there will be macrocytosis. So in many studies they have proved that if it is more than 110 femtoliter with presence of an hypersegmental neutrophils, we can easily diagnose a case of vitamin B12 by more than 95%. So classically they will have macrocytes, macroovalocytes, they will have normal MC&C. Platelet may be reduced not much, but it can reduce up to like say 80,000 to 1 lakh, it will be like %. And you will have a classical hypersegmental neutrophils, and RDW will be like increased. So because of increased size and different shapes, we will have anisopoikilocytosis. So we see in this picture, we can see that macroovalocytes, we can see different shape of teardrop cells, as well as there are different shapes and sizes of cells. We can see hypersegmented neutrophils. So the morphological features of vitamin B12 deficiency. So here comes the problem. So megaloblastic changes, we know that in MDS also it is a feature. So don't jump into a diagnosis of an MDS before excluding a vitamin B12 deficiency. Or any cases of like recent history of tuberculosis where patients have received ATT, especially INH and all those drugs that can cause megaloblastic changes, and we should be taking into consideration. So even if you go into properly morphology, when megaloblastic changes, we can see a typical immature to mature pattern. If you see that typical megaloblastic changes without any erythropoietic changes. So if you see both megaloblastic and dysplastic changes, then we can consider that patient can be a case of MDS. But don't jump to a diagnosis of MDS unless we are having a proper clinical history and proper morphological and cytogenetic features. So the answer for this question is like vitamin B12. So I have given a trial of vitamin B12. Within a week, patient had a complete, almost complete resolution of the symptoms, and her HB gradually started improving, and now she's doing better. So we moved on to second case. The second case is a 60-year-old female patient who presented with the complaints of EC fatigability and weakness, that is anemic symptoms. For that, she has like referred to GP and confirmed to have a severe anemia. So on CBC, she had hemoglobin of 5 gram, WBC count of 5,500 with normal differentials and platelet of 7.8 lakhs, slightly increased, and the MCV there is macrocytosis 108 femtoliter, and the tick was 1%. Her LFT, RFT and other electrolytes were normal, and considering her severe anemia in an elderly patient, the parvovirus was done, vitamin B12 levels were done, and HIV, HBsAg and HCV were done. Those are all non-reactive, and vitamin B12 and parvovirus were also in normal ranges. So for this anemia, she received 1 point PRBC they're requiring every 3 weekly to maintain HB of 8 grams for the past 6 months. So bone marrow was done. So in this bone marrow, what will you not expect in the bone marrow? So for a guest, the elderly female with an isolated anemia and thrombocytosis, macrocytic anemia, thrombocytosis, vitamin B12 are normal, recovering blood transfusion for the past 6 months. So anemia with recovering transfusion with a macrocytic anemia and thrombocytosis. So we are suspecting an MDS, bone marrow was done. So what can you expect? So number one option is hypercellular bone marrow. Of course, in an MDS patient, we know that 90% of our cases are hypercellular bone marrow. So we will have an hypercellular bone marrow that will be present. Number 2, hypolobated megakaryocytes. In any MDS case, that this megakaryopoiesis can be seen as a part of panmyelosis as a part of this megakaryopoiesis or as a part of multiple lineage dysplasia. Cytogenetics 5q deletion, of course, it is a classical case where 5q deletion patients will present hypolobated megakaryocytes, and that can be present. And macrocytic anemia with thrombocytosis that we have already shown here. And these are the things that can be seen in the bone marrow slides, where we can find many increased number of thrombocytes, platelets in the background, and ring sideroblast more than 15%. So this is not the correct answer. So what we are dealing with? So we are dealing with a case of an MDS with an 5q deletion, where classically we will have in the bone marrow this type of megakaryocytes with eccentrically placed nucleus and monolobated nucleus, and this can be like increased or it can be decreased also sometimes, and you will have increased erythroid cell lineage hyperplasia. Overall bone marrow can be normal to hypercellular. Other cell lineage dysplasia generally won't be present, but it can be present, but you have to do a cytogenetic that is very important. In that we can give 5q deletion. So this is a bone marrow biopsy of the same patient, where we can see that typical hypolobated eccentrically placed nucleus of this megakaryopoiesis. So a few just remembering point for MDS with isolated 5q deletion. So one of the commonest type of MDS type, where we can present with macrocytic anemia and thrombocytosis. It can generally present with 5q deletion. Sometimes it can be with other deletions also. Generally, we won't have increased blast in the bone marrow, but they will have non-lobated and hypolobated nucleated megakaryocytes. Plus, commonly present in the elderly patients, we have that classical 5q deletion at a particular point, where that lead to haploimmune of certain proteins, leading to this proliferation of this glow. So these patients will be like treated with lenalidomide. Classically, they are around 70-75% of the patient will respond to lenalidomide. So that is the beauty of this drug, and this is well manageable, and patient will become wonder within a month of treatment, and they will become transfusion independent. So moving on to the case 3. If you see the case 3, 67-year-old female patient who presented with the complaints of easy fatigability and weakness. So for that she went to a GP, found to have severe anemia of around 5 grams, and platelet counts around 80,000, but WBC counts are normal, and the peripheral smear examination, the different counts are normal, but there was macrocytosis. Retic is low, less than 1%. Parvovirus not detected, triple H is non-reactive, and B12s are normal level, LFT, RFT are normal. And she is also requiring multiple blood transfusion, requiring every 2 weekly to maintain a HB of 8 grams for the past 3 months. So I have done a bone marrow. So what will you not expect? Because I am suspecting an MDS, an elderly patient who is having bicytopenia with features of an MDS, like requiring multiple blood transfusion. So I am considering an MDS and having a bone marrow. So what investigations I won't require for diagnosis of an MDS? So first thing is like that bone marrow is required or not. Of course it is required. We know that without bone marrow we cannot appreciate the morphology of MDS features. Iron stain is important to document the features of sideroblastic sideroblast. Cytogenetics, of course, very important. Molecular studies could be useful. Flow cytometry also could be useful. So among these 5, if you ask me which is the most important one, which is not required for diagnosis of MDS, I would go for flow cytometry. So in this case, we can see that it's the same patients, like where we can see macrocytic anemia, there is thrombocytosis and iron signs stored, this type of sideroblast, particularly present in the perinuclear region, type 3 type of sideroblast, and we are having erythrocytic hyperplasia in the bone marrow. So it is a case of an MDS ring sideroblastic patient. So here we can see cytopenias and ring sideroblasts represent more than 15%. So in this type of people, like when the SF3B1 mutation is present, we can diagnose this patient even if RS cells are more than 5%. So that's why molecular studies is very important in some of the cases of MDS. Okay. So before diagnosing this case, we should also exclude non-neoplastic causes of ring sideroblast, that includes alcohols, toxins, certain drugs like INH, copper deficiency, and we also, if in a young patient, we should also exclude a possibility of a congenital sideroblastic anemia. And we know that prognosis of an MDS-RS patients are like, particularly they do well compared to an multilineage dysplasia. So they have very good prognosis. Now we are having a drug for this entity, luspatercept, that I mentioned in the last session. The drug is recently approved, and this is also a wonderful drug. And along with lenalidomide, if they are not responding to lenalidomide, you can go for luspatercept. They will become transfusion independent, and this specifically works for MDS with RS patients. So the answer is flow cytometry. So why flow cytometry? But if you see, flow cytometry is not required for a diagnosis of MDS, because till now we are like our diagnosis based on morphology and cytogenetics. So with that only we can go. So when we have to use flow cytometry, that we will like discuss in few slides. So going to the fourth case. The fourth case is a 56-year-old male patient who presented with a history of breathlessness, easy fatigability for the past 3 months, no history of any bleeding, no history of any fever, no significant organomegaly. The past history was not significant, and he received one blood transfusion last month, but still feels having the same symptoms. So CBC showed a HB of 5.5 grams and WBC count of 3100, and we are having around 60% polymorph. So ANC will come around 1500, platelets around 80,000. You see the MCV is raised 104, retic is 0.8%, vitamin B12s are normal. So considering an elderly male presenting with anemic symptoms, CBC showing a pancytopenia and a retic of less than 1%, so it becomes an hyperproliferative type and macrocytic type of anemia. So my first diagnosis will be like clinically MDS. So I underdone a bone marrow. Bone marrow showed hypercellular bone marrow. Blasts were 4%. There is no dysplasia. There is no ring sideroblast. So biopsy also showed hypercellular marrow with multilineage hematopoiesis. There are no ellipse. There are no fibrosis. There are no increased blast in the biopsy. That was confirmed with CD34 IHC. And karyotype is also normal karyotype. So in this patient, what will you do next? Should I go for a flow cytometry to confirm whether it is MDS, or should I do a molecular studies, or should I do the both, or none of this required? I can simply say it is an MDS unclassifiable. What should I like put this patient into the category? So the answer for this question should be like both molecular studies and flow cytometry. Why? I will discuss this thing now. So molecular studies is very important because we know that certain MDS can be diagnosed with features of molecular, especially the SF3B1 mutation, which is present. We can directly even call it as an MDS, the specific subtype. Apart from that, we can identify multiple driver mutations, and that can also predict the evolution of an MDS patient. And flow cytometry is definitely useful in some cases where you are not sure about your diagnosing an MDS. So even though clinically there is a basket waste basket classification in the WHO called MDS unclassified, where used to put, if you are not fitting, patient is clinically having a MDS type of picture, having some amount of dysplasia, either the hypercellular bone marrow, some pancytopenia, we used to put in unclassified, but without having a proper diagnostic. So here flow comes to importance. So flow can detect, nowadays like flow can easily detect these type of patterns, and in any clinically suspected case of MDS, we can definitely run a flow to look for MDS pattern. So in this next few 3 slides, we will talk about how to diagnose a case with the flow cytometry. So flow cytometry may support the diagnosis of MDS, though it is recommended by European network, but it is not mandatory for diagnosis. So where cases of minimal morphological dysplasia, or they don't have any cytogenetic abnormality or molecular abnormality, a flow can help for the diagnosis. So in another ways, we can say even a patient is having a normal flow cytometric findings, so we can always think about to exclude other causes of cytopenias, and then some patients might require close follow-up, and some we can retest after some time. So we can exclude a case of an MDS if you are having a doubtful case. That is the importance of flow. So this is the European Leukemia Network, which is like showing that if FISH and flow is recommended but not a mandatory test, so that can be used for diagnosing a case of MDS. So, so what are the things we look into flow cytometry? We are like generally we look into immature blast, we look into maturing monocytes, myeloid cells, erythroid lineages. But unfortunately, we cannot assess the dysplasia in megakaryocytes, eosinophils, basophils, mast cells, dendritic cells. Those cannot be applied in the flow cytometric analysis for MDS. So these are the cells, as I mentioned. We will assess progenitor cells like myeloid lymphoid cells, maturing myeloid and monocytic cells, and erythroid cells. So what will you see? You will see a maturation pattern based approach or an aberrant expression of antigens. That's what we will see in the case of an MDS. So these are the different markers which are used for assessing MDS in a case of MDS. Where erythroid commonly used markers are CD4571, CD35, 117, CD36, and in myeloid progenitors we use all the immaturity markers including CD34, 117, HLA-DR, 11B13, and apart from that we can use CD7, 56, 19, 5, 15, and in maturing neutrophils accordingly we have used the same, and we can also use the monocytic method that has been described. So what will you see? So if we go into that immature myeloid monocytic series, either they will have an increased expression, or they will have a decreased expression, or they will have a heterogeneous expression. So anything which is like abnormal from the normal pattern, that can be detected easily by a flow cytometry. So for example, in myeloid monocytic progenitors, we can see that the CD45 can be totally absent, or it can be increased, or it can be decreased. Same way it goes with CD34 expression as well as CD117 expression. So you can also have a comparison with like for example asynchronous expression of 11B and 15. So in that also we can see some aberrancies that can be detected in the myeloid and monocytic features. Coming to the neutrophil, like in neutrophil, we generally see with side scatter with the lymphocyte where the expression will be decreased, and with the relationship with that CD13 and 11B will have an altered pattern. Same goes with the CD13 and 16 or CD15 with the CD10. For monocytes, we can have relation to the HLA-DR with the 11B where we have an altered pattern, and the maturation pattern can also be somewhat immature, and expression can be increased or markedly decreased, or presence of a newer marker or another infidelity marker like CD56 expression can be seen in the monocytic series. In coming to the blastoid series, then blast it can be increased with some aberrant markers, or it can be totally absent with totally decreased and absent expression of the immaturity markers like CD34. In erythroid, we can see an altered pattern between CD71 and CD35A. And we can overall sometimes in the case of an isolated case of an MDS with erythroid hyperplasia, we can see increased percentage of nuclear erythrocyte. That is also one of the features of MDS for assessing dysplasia and flow cytometry. So if you see here in this picture, the immature erythroid cell lineages will have all these features of immature markers. But normally in any case, in a given case, it should like come down after some time. So in a mature erythroid cell lineages, you won't see CD34, 117, HLA, DR and all. So you will be seeing only CD71, CD235, 235A or CD36. So if these agents are present, then we can call it as an myelodysplastic changes in the erythroid cell lineage. For example, see in this picture. So this is a CD71 and this is a CD35, 235A. In a normal bone marrow, we can see it both will be positive and will be present as a chunk in this area. But in an MDS case, we can see the CD71 has an heterogeneous expression, like say some dim to strongest expression. So if it have a typical this type of abnormal pattern of morphological pattern, by that we can diagnose, okay, this could be a case of an MDS. Coming to the antigen expression of monocytic differentiation, for monocytic, if you see that we can be divided into three major categories like monoblast, promonocyte and monocyte. So we can see clearly that the monoblastic region will have CD34, HLA, DR and CD64, 117. Among that, we can see the CD34 and CD117 will coming down, and rest of the markers will come up and will start appearing in the promonocyte monocytic region. So anything abnormal from this type of pattern will be like called as an abnormal pattern. So in this picture, we can see in here, this is the site scatter with CD45 normal expression. So this is the region of neutrophils, this is the region of lymphocytes, this is the region of the monocyte. So this is the red one is shown is in this box is the monocyte. So we comparison is a normal patient. This is an MDS patient. You see here the monocytic expression. What is the percentage? And see the percentage of expression here. It is increased in expression as well also increased in the number. This is an abnormally increased CD45 expression monocytic cells in the case of an MDS. The second picture we can see a comparison within CD11B and CD13, where in a normally we can see a lesser number of cells expressing this both the CD13 and CD11B. But if we see in a case of an MDS, a classical so-called Nike pattern, a pattern like kind of a tick type of pattern, where it is like attributed. Why? Because 11B has an heterogeneous type of pattern, including 13 also an heterogeneous type of pattern, so leading to a so-called Nike pattern. So this is an abnormal pattern. So this is the normal pattern, this is an abnormal pattern. So same goes with the 11B. If you compare with the HLA-DR in an MDS patient, we will have some something called waterfall pattern. See like here, normally we'll have a very few cells expressing this HLA-DR and 11B together. But if in an MDS patient, it will have a heterogeneous expression of both, so leading to an waterfall type of pattern. So an abnormal pattern can be seen in monocytic series. So while looking into these series, we can suggest, okay, this could be a case of an MDS. So now coming to the neutrophil differentiation, this figure looks like that some kid has drawn with different color pencils, but yeah, it looks complex, but it's very simple. If in a case of neutrophil differentiation, we can see that CD34 is a myeloblastic marker. If once a cell started maturing towards promyelocyte towards the band neutrophils, the CD34 will go off. So this one of the commonest marker that should be like present only at the blast region. It should be like get absent from the other lines. So this is the different patterns will be present at different stages. So if you find anything abnormal in these patterns, like you can diagnose a expression, antigenic expression abnormalities in neutrophils in MDS. So this is the first, in the first picture we can see that normal maturation, normal pattern of a given case was mentioned. This sites are scattered CD45. So this red color is that indicating the neutrophils, and this green color is the monocyte, and this purple color is the lymphocyte, and this is that orangish color type of this is for erythrocytes or debris or something like stuff. So if you see properly here, in normal patients we can see that different immunostains have been used, and we can see like CD45, CD34 and CD10. So this is a normal expression of a neutrophilic series where it will be like present as a band, thick band. But if you see an MDS patient, this is a normal patient, is an MDS patient with similar CD45. See that band has decreased in intensity. Even it has been like accumulated more towards here. So somewhat myeloid series like precursors being increased, but the maturation cells are like little bit decreased. That is the indirect evidence like it is like we are able to see here. Same goes with CD34, where we can find more CD34 positive cells are seen, but it is it is not present in the other cell lines. Like there's a totally different type of pattern when compared to a normal pattern. Same goes with the CD45 and CD10, where we can see a decreased expression of CD10 but increased expression of CD10 in the normal pattern. So this is how a neutrophilic series will look in the flow cytometry in a case of MDS. So based on this we can put calculations, and the more the value, there's something called flow score. The flow score, if it is more than more than 4, it will be like termed as severe. If it is more than 2 to between 3, it's moderate, and if it is like less than 1, generally we'll call it normal expression. So that's how like flows becomes very important in some of the doubtful cases, and we can nowadays like many of the labs centers who are running flow cytometry, they are well versed with this type of morphological change, antigenic expression and flow patterns, and it is very useful in diagnosing a case of an MDS. So moving on to the fifth case. The fifth case is a 43-year-old male patient. Is symptomatic since 1 year, initially presented with easy fatigability and found to have anemia with moderate thrombocytopenia. So he was having bicytopenia, requiring blood transfusion every monthly, requiring for the past 1 month, 3 months. And also recently started having easy bruisability, like having bleeding symptoms for the past 1 month. And there is no significant past history, there was no morphology, no other clinical features. So a 43-year-old patient with bicytopenia, requiring blood transfusion, and recent history of bleeding symptoms. So CBC showed typical pancytopenia with platelet count of 22,000 and HB of 6, and then peripherally we can see around 2% circulating myeloblast. MCV was 108 and retic count 0.5%, that is less than 1%, and other LFT RFT were normal, and I have done a bone marrow because there was circulating blast was there, so I done a bone marrow. So bone marrow showed hypercellular bone marrow, and then blast percent I counted was 8%. There is dysplasia in all 3 cell lineages. Ring cerebroblast is less than 5%. Cytogenetic we have done, it is 5q deletion, and there was 17p deletion. So this is the bone marrow picture of the same patient. Here we can see that these blue color arrows are the blast, and there is some amount of erythral hyperplasia in the background, and we can see a micromegakaryocyte with an eccentrically placed nucleus, micromegakaryocytes, and there are few binucleated erythroblast also seen. So based on that, this is I diagnosed the case of an since the blast count does not increase more than 10%, I have diagnosed as a case of MDS EB1. So in this case, will you do with we will do a bone marrow biopsy, or you will run a flow cytometry, you will do a molecular studies, or you will do all the 3? That is the question. So can you just stop with the bone marrow aspiration? Do you require a biopsy or not? Or do you require flow cytometry, though you have already seen a blast morphologically that we have counted properly? You have seen 8% blast in the bone marrow, and you are having 2% blast in the peripheral blood, and patient is also typically presenting with the features of an MDS. And can you diagnose with only with these features? So basically, no. We need all those investigations. We need bone marrow biopsy. Why we need a bone marrow biopsy? Because it can give more clues, especially to rule out an evolving AML. So EB1, I will come into the management because it has some implication of management purpose. So calling it an so when there is a more number of blasts in the bone marrow, so patient might need some amount of cytoreduction therapy. Even a low risk MDS, when blasts are not increased, we don't recommend cytoreduction therapy. You can give some other treatment like lenalidomide. You can give hypomethylating agents, those type of drugs. So biopsy is very important in a given patient of my MDS. So where we can rule out blast clusters. Also you can look for ellipse. You can also look for fibrosis. So there is an entity called MDS with myelofibrosis. It's very rare, but you can also see that can be confused with your myelofibrosis. In those type of cases, molecular studies becomes very important. And also we know that for prognostication, and I told you this is a case of 43-year-old, like roughly a young patient. Why a young patient should have a dysplasia? So you should have in your mind, and you should do a germline mutation. You should think of germline mutations. You should do particularly specific type of molecular panel to detect those germline myelodysplastic myeloneoplasm. And flow, as I told you, flow is important in this case also because we know that there are certain AML that can show MDS-like pictures. It can show micromax. It can show pseudoperidot anomaly in the neutrophils, hypogranulation. So based on only with morphology, if you are just diagnosing a given case of with an MDS with EB1, there are some entities that actually you can pick without cytogenetics also it can present. You have to be keep in mind. And morphology, it will be sometimes very tricky. Sometimes you can miss. You will say that it could be blast counts are only 8%, but if you do a flow, it will be coming around 35%. So in this patient, actually I ended up calling it as I managed this patient. I followed this patient. Within a 2-3 month period he progressed. So though I have labeled as EB1, I done a biopsy, but after 2 months I done a bone marrow, again repeat aspirate, and I done a flowcytometry. At that time he had a blast percent of 35%. So I have to call him now as an AML. Then I treated him like an AML patient. So yeah, a few slides about things about this thing only. MDS with the multilineage dysplasia. It is one of the main classifications of the MDS, comprising around 30% of the cases, where we can have blast can be less than 1%, but if you are having blasts or more, we will classify accordingly with the excess of blast 1, excess of blast 2. So, but always keep in mind, if you have always doubt in terms of management, because as a pathologist, you should always prompt the clinician to go for a flow, at least to quantify the amount of blast. Sometimes morphology can be really tricky. It's from my own experience I'm talking about. Okay. So going on to the case 6, 43-year-old male, a painter by occupation, is symptomatic since 1 year. And is presented with EC fatigability, found to have anemia and moderate thrombocytopenia. And platelet, this patient required multiple blood transfusions in the recent past, and he had a history of bruisability for the past 1 month, and no other significant history, no organomegaly. And he also had typical pancytopenia. And he also gives an history of similar history of complaints in his family member. And similar type of bleeding symptoms, and that femur also affected, and he also not died, but he is he also present, and he was given some treatment. So he had macrocytic anemia, reticulocyte count is less than 1%, and LFT-RFT was normal. So typical patient with an younger 43-year-old patient presenting with bicytopenia, requiring blood transfusions, and considering a longer period. So I thought it could be an MDS, because in acute leukemia and all those stuff, generally you will have a recent history, not like a 1 year history. So keeping in mind, I thought it could be a case of an MDS. So I done a bone marrow. the bone marrow showed hypocellular bone marrow. Blast was 1%. Predominantly there was lymphocyte and plasma cells. So MEX were not seen in the aspirate, and erythroid and granulocytic series are markedly suppressed. Because I have sent cytogenetics also, that it came to be 7q deletion. So I thought it could be a case of an aplastic anemia, So would you just diagnose based aplastic anemia based on these findings, or do you require few more tests? That is the rationale behind this question. So bone marrow biopsy to confirm aplastic anemia, will you do or not? Yes, I will do. PNS studies, I will do. Molecular studies for myeloid neoplasm and general mutilation. Just now we explained that it's an younger patient and he has a family history, so we have to do. NGS for clinical exam for inherited bone marrow failure syndrome. Okay, so we will go one by one. So in this patient, I will do all the tests. So relatively younger patient who presenting with pancytopenia has a family history of similar subtype of disease in the family. So bone marrow biopsy is very important because we have to rule out a case of malignancy in a given case of pancytopenia. Also, we can prove it could be an aplastic anemia or it can be a hypoplastic MDS. So these are the commonest 3 differential diagnoses in a given patient with pancytopenia. So we have to think all these 3, and bone marrow biopsy becomes very important in that. And PNH clone is also very important because you know that PNH, though classically presents hypercellular marrow, in a given point of time it can also progress, it can cause a hypoplasia, and it can be confused with aplastic anemia and MDS. And some 10% of the MDS can also have hypoplastic, so-called hypoplastic MDS. So even in some cases of PNH clone can be present in the aplastic anemia, it can present PNH, MDS also that can progress, and it can in a rare patient can also progress to AML also. And molecular studies, as already I described, we need to find what are somatic driver mutations, and if it's a younger patient, we should look for germinal mutations. In any given younger patients, there are some inherited bone marrow failure syndromes that can mimic like aplastic anemia. Even though age is 40, sometimes we end up doing when a positive familial history is there, and less than 40 or 50 years old, like we generally do this clinical exome for inherited bone marrow failure syndrome. So we have found in a many number of people found a Fanconi's anemia that will present very lately also. So they might not be pathogenic, they might be heterogenic in their expression, but that much is sufficient enough to cause pancytopenia presenting with an aplasia. So this is the case of an hypoplastic MDS. We can see here this picture showing an around 90% hypoplasia, around 10% cellularity is there. But in high power, if you look for it, you can see a dysplastic megakaryocyte, and sometimes could be some abnormal large cells looking blastoid. So in those cases, if you run a CD34, we can pick up those CD34 positive blastoid cells, like blast cells we can identify. So CD34 becomes very important, and to look for dysplasia, whatever the cellularity for a given cellularity for hypoplastic MDS, you can definitely, if you are good at morphology, you can look for those findings. So as we mentioned in the last session, a hypoplastic MDS can behave like an aplastic anemia, or it can behave like an MDS. The treatment is totally different for both. In aplastic anemia, they will give immunosuppressive therapy like ATG, that is anti-thymocyte lymphocyte infusion, or we can give cyclosporine. And in MDS, we have to treat like an MDS patient because there are more chance of leukemic elevation, so they might require hematogenic stem cell transplantation. If you see that these are clinical features of related bone marrow failure syndromes of aplastic anemia, post-aplastic anemia, MDS, hypoplastic MDS, and MDS. So most of the features are somewhat common, but one main thing we can say that if you go for dysplasia, the dysplasia is commonly seen in the MDS group. So that's why I'm telling you have to look for dysplasia very carefully in a given case of hypoplastic anemia, and also to look for blast. If you see the blast, so morphology, if you're able to pick up, it's good, but you have to do a CD34 immunostain to look for a blast. Okay, so a blast can be seen in all other features excluding the aplastic anemia. And cytogenetics generally will be normal in aplastic anemia, it will be normal cytogenetics, but having given case, normal cytogenetics does not exclude a case of an MDS or hypoplastic MDS, because even aplastic anemia also you can have many patients can present with deletion 7q, they can have other loss of heterozygosity, so cytogenetic cannot be like all time it can be normal, so it can also have some abnormalities. So how can you differentiate? So if you do a recent molecular studies, you can differentiate hypoplastic MDS from aplastic anemia that we have gone through last session, so I'm not detailing about it too much, but you can differentiate based on molecular studies. We can differentiate on based on, even if it is present, we can clone size, we can differentiate hypoplastic MDS from the aplastic anemia. So coming to the last case, it's a 15-year-old female patient who presented with 1-year history of anemic symptoms with UC bruisability. She attained menarche at 12 years, and since last 6 months is experiencing heavy menstrual bleeding, changing around 8 to 10 pads per day with passage of blood clots. She is having intermittent high-grade fever, requiring hospital admissions and IV antibiotics. She has become transfusion dependent since last 3 months, requiring 2 to 3 PRBC bags every month, and 3 months back during a initial hospital admission, she was diagnosed to have aplastic anemia by a treating GP and was started on cyclosporin and danazol, but her symptoms are not resolved. So when she came to us, she had a pancytopenia, and she had predominantly lymphocytes in the peripheral blood. Retic is 0.1 and LDH is low, and so we have advised, so some of the hematology has seen, they have advised some new investigations, some repeat investigations. So now she has came to us like for a second opinion. So there are list of blood tests have been advised. So what you can avoid in her? So will you repeat a bone marrow aspiration biopsy with CD34 immunostain, iron stain, cytogenetics? Will you do chromosomal breakage studies, PNS studies, flow cytometry? Which are the following you can avoid? So in this case, flow cytometry won't be much of useful because we know it is a case of an aplastic anemia. So in a given aplastic anemia means, pancytopenia picture, the predominantly an hypoplastic type of picture, because peripheral blood also shows a typical hypoplasia with predominantly lymphocytes. So it looks like an aplastic anemia. So even in a hypoplastic MDS, in a given case, the number of blasts cannot be like appreciated with the flow cytometry, because many times it will be like either dilute, or sometimes it will be useful, but not always it will be useful. So flow cytometry can be safely excluded if you want to go through, because other tests are very important. For example, biopsy. Of course, I just know in the previous case we have seen that CD34 immunostains becomes very important in hypoplastic MDS to pick up the blast, and iron stain is very important, we know that. And cytogenetics, yeah, of course it is important to define MDS, defining abnormalities. So this is a 15-year female patient who presenting with like a pancytopenia, so we have to exclude the underlying inherited bone marrow failure syndrome, especially your Fanconi's anemia, DKC or SPDS. So we have to do that. PNH studies, as I told you, aplastic anemia might have PNH clone that can progress over time. So you have to monitor every yearly aplastic anemia patient what's the PNH clone. That's the importance of PNH clone, because that PNH clone will be treating for aplastic anemia that can slowly progress, then finally patient will present as a PNH type of picture. So we have to monitor PNH clone also. So, and apart from that, we have to do an HLA typing of patient and sibling, which is very much essential for hematopoietic stem cell transplantation, because in aplastic anemia nowadays in younger patient, that is a treatment of choice that can cure the patient of aplastic anemia. So yeah, that is the very good thing about seeing aplastic anemia nowadays, like 90% cure rate with the hematopoietic stem cell transplantation. So a few words about childhood MDS. So they are very rare, less than 5%. And most of these patients are like, secondary to some previous history of cytotoxic therapy or inherited bone marrow failure syndrome, and very few patients can have an acquired second severe aplastic anemia. though it is common in elderly patient, but childhood patient can also present with. So if you do a germline mutation, if you see among that Cat2 mutation is the very commonest, one of the commonest mutation, Cat2 mutation, that predominantly presents with the neutropenia and thrombocytopenia, and most of these patients will have hypocellularity, and some mutation pathways are also involved. And WHO has put on one something, a provisional category, so-called refractory cytopenia of childhood, where where it is defined by presence of bone marrow blast less than 5%, peripheral blast less than 2%, and they will have a hypocellular bone marrow. And monosomy 7 can be seen, which is one of the commonest cytogenetic abnormalities in RCC. And but generally they might have normal karyotype also. They can have trisomy 8 also, but generally they will have stable disease. And to diagnose this RCC in a childhood, you should need at least 2 biopsies 2 weeks apart at 2 different locations to document the disease. So you will generally see the micro megakaryocytes, and erythropoid can be like increased, but granulocytes can be decreased. So this is the WHO criteria for RCC given the WHO. So this is a picture showing the refractory cytopenia of childhood, where we can see erythroid colonies are increased, overall cellularity is decreased, and so it's very difficult to differentiate as to particularly say in terms of morphology, but this can be treated like other aplastic anemia only. So you can, if you anywhere treatment is like becomes almost similar, because if the patient is present to have RCC, they have to undergo for hematopoietic stem cell transplant. So in terms of management, it does not going to matter, but in terms of diagnosis, it becomes important. So for that, we have to specific morphology. You have to look for micromegakaryocyte dysplasia, look for dysplasia, look for CD34 increased count, look for erythroblastic increased erythroblastic colonies in the RCC even compared to the acquired aplastic. So last slide, to like in any given MDS patient, we categorize the patient as lower risk and high risk based on IPSS criteria. In lower risk patient, we will give generally growth factors, luspatercept, hypomethylating agent, lenalidomide. In higher risk patients, most of the patients will require allogenic stem cell transplantation. To bridge that, we might give some cytotoxic therapy in forms of decitabine or azacitidine, or some chemotherapy can be given based on the comorbid status. Then once the patient becomes remission, we can have to take for allogenic stem cell transplantation. So this is what about MDS. I hope I taught you something which can be like easily diagnosable, though it is so complex disease. So if you have any questions, I am here to answer you all. Thank you.
Thank you, Dr. Murali. Very nice presentation. My first query is, how commonly do you see MDS RCC?
Truthfully speaking, very difficult to diagnose as such, unless you have a suspicion in your mind. Since I am right now working in a pediatric center, so we are getting referral cases. So because of that, probably I don't know, I have seen 1 or 2 patients, not more, but it's not that much common. It's definitely difficult to diagnose, truthfully speaking. One instance I can give you. One patient recently came to us as an pancytopenia with typical features of RCC type of picture. We thought it could be RCC, and we have done finally all the markers. We have done flow and all those stuff. So nothing was specific of RCC. Then after we have just observed that patient, we did not do anything. After 3 months, the patient became a totally almost normal counts. So that was a transplant aplastic aplasia. Secondary to then we got retrospective history. She got given some vaccine, I think MMR vaccine or something like that. After that, patient suffered some aplasia. That recent history of viral infections, that can present with transient aplasia also. Very difficult to diagnose, but it can happen.
Right. And very nice system which you have used to differentiate, because aplastic anemia, hypoplastic, MDS occurring following aplastic anemia, very difficult situation, but the table which you have shared and the way you have explained is so nice. And also the importance of flowcytometry in cases of MDS is so important, and we should use. Very nice presentation, very nicely presented, nicely taught. MDS is not an easy subject. It's a tough subject. Thank you so much, Dr. Murali, for taking out time. You're so busy. Thank you so much.
No,
please,
sir, it's okay.
Please share the PDF.
Sure.
We'll share with the students. Thank you so much once again. God bless you. Take care. Bye-bye. Thank you so much.
Thank you, sir. Thank you.
Bye. Thank you.